Welcome back to Talk Ottawa. Let's continue the discussion about healthcare and doctors' fees and the future of how we pay our healthcare professionals in a time of growing budget pressure at the provincial government. We're joined by Ann Clarke, who is a registered nurse and also the Vice President for Region 2, which includes the Ottawa region with the Ontario Nurses Association. Welcome to you.
Thank you.
And Dr. Barry Dworkin, who is a family doctor here in Ottawa, and you also hear him regularly on CFRA radio. Welcome to you.
Thank you, Mark.
You have taken up this debate and you've been engaged in writing about it. There was a story in The Citizen that featured you this morning. So give us a sense in a nutshell why you're concerned about the changes that are coming, that are being imposed by the provincial government, and how they're going to impact not just what doctors are paid, but actual healthcare provision in the province.
Well, the main issue is that over the course of about 5 years, the government has encouraged the formation of health teams to provide a wide basket of services to patients. So I invited Pauline Tam to come into the office to shadow us, to see exactly what we do, so that she'd have it's always better when you're seeing something as opposed to getting a theoretical, I do this, that, and the other thing. So the issue is there have been a lot of investments made in order to set up these centers to provide nurses services, to provide counseling services, full after-hour service, on-call service, weekends, providing full comprehensive care, following up with patients, being able to do a lot of things remotely using electronic records. So all this infrastructure, all the costs associated with not only setting it up, but maintaining it, are built into the structure within which the government pays physicians. Because what happens is that the physician is paid a monthly salary or fee based on the number of patients that they are seeing. And then 40% of that goes into the operations of the practice. So the physicians are covering the costs of maintaining the infrastructure that the government wanted us to set up and that we signed contracts with them to do in order to provide this whole basket of services. And it's also to encourage patients to come to the practice, not to go elsewhere, not to go to walk-in clinics, in order to maintain continuity of care. So the issue now becomes, now that this structure, this house has been built, and it's functioning well, everything is in place, and you have a well-functioning machine that is doing what it's supposed to do and improving all the time, because the way it is structured is it allows you to hire more professionals. With those professionals, more fees come in, you get another few physicians, more money comes into the office. Our plan this year was to hire a nurse practitioner or a physician assistant to even provide more patient care, to try and keep the structure relatively even in terms of revenues coming in and amount being spent. The philosophy of the practice and many of these teams is to keep it relatively revenue neutral and to provide the care, and the physician, what they're left with is their take home. But what's happened now is that the fee structure, which is a very complex structure, it's not a simple, here's your money for this particular service. It encompasses all the different things, all the variables, all the different services that we provide, everything from renewing prescriptions in the morning and reviewing test results, calling up patients, letting the nurses know to call a patient to let them know this is what they need to do, telling a patient that they need to come in a couple of weeks to follow up on their blood pressure because the prescription they wanted renewed, it's already been a year and I haven't seen them in a year, so I need to do blood tests to assess kidney function and stuff. It's all that minutia that goes on behind the scenes that people aren't aware of that the fees cover. And the government now is removing those fees, and it plans to from the end. I remember I gave you those documents, Mark, that illustrated all the different fees that they're looking to cut. And those go directly to that kind of managing of care. And when that's taken away, that infrastructure can't be supported anymore. And if you can't support that, the patients then suffer because you can't provide the same level of service that they're now used to and that they should be getting.
So let's clarify a couple of points on that. So number one, you have the option, I guess, of when it comes to a patient of your family practice, of rather than billing the province every time they visit or every time they require something, of having a flat fee for that patient for the year. Is that right?
That's right. It's called the rostered system. So patients register with the practice, and when they register, it's an agreement. And the agreement is, we're going to come and see you, and we're going to try and provide you access. So either by phone, call in, there's registered times, there's urgent care services 12 hours a day, there's weekends, there's holidays, There's drop in and see the nurses, call in and see the nurses, call and leave a message, we'll call you back. So all that is to try to encourage continuity of care. And you're paid a flat rate for that, anywhere between $50 to $180, and it's based on age, per person per year for unlimited service. There's a small component that the government uses to make sure that you're actually seeing patients, right? It's not a matter of I've got 1,600 patients registered and I'm going to get paid for those patients and I don't see any for the year. So there's something called shadowing or shadow billing. So it's a small percentage of what they originally would pay as a fee, but that's used as a means of setting up that infrastructure to be able to track those patients and show what you're doing. You're trying to show that they're getting value for money, and that's a fair agreement.
And out of that, you pay all the expenses for your practice.
Correct.
Out of that fee that you get for each patient.
Correct. And so in the Citizen article today, my expense sheet was in there for the practice.
Right.
And so as an example for viewers, our expenses were about $749,000 for October, beginning of October to May. That's our fiscal year. And our revenues were $750, so it's a $1,000 difference. So, and that's just to cover the first 5 or 6 months of practice. So you just prorate that and multiply it, and you see how much it costs to run the practice. So any reduction in fees when you have 10 physicians accounts for a quite significant percentage. You're dealing with a very narrow margin. You're already paying 40% of your income to maintain the practice for your patients, because that's essentially what it is. You're providing the infrastructure, the physicians are providing the infrastructure to allow patients the ability to come in and take advantage of what we have. But when you start to cut, even if it's 5, 10%, that still amounts to a lot of money that's now not available to go into the practice.
All right, Ann, let's bring you into the conversation. How do you see all of these changes impacting on the nursing profession in Ontario?
Well, we feel that if they bring in the austerity budget, it will lead to another huge round of cuts and layoffs and restructuring. And I lived through the restructuring in the 90s, in which they closed thousands of hospital beds, laid off thousands of nurses, and really downsized the whole system, and have slowly had to bring it back up. And the family health teams, I think, were a great innovation by the provincial government. It diverts people from Emerge. I belong to one where I live in Kanata, and instead of you calling up and being told, go to the nearest Emerge, you now can see a physician. So I mean, the whole system, that is a plus for the Liberals. And now they actually want to dismantle it, and I think it will impact emerges, it will impact wait times, and we'll just have a huge backup again. But this austerity budget will mean a whole round of layoffs and cuts. And we're already seeing them. In Scarborough Hospital, they laid off 60 RNs. There's been about 240 in this Ottawa area in the past few months, and that's cuts to programs like diabetic nurse educators in some hospitals. And anytime you cut a program, that directly affects patient care. So it's not going to be pretty.
So you're predicting that in local hospitals we're going to see, number one, job cuts among your ranks, and number two, more pressure, more demand, more people going to emergency, because the family practices won't be able to sustain them anymore.
Well, for instance, people are already queuing up in Emerge. I was just in Brockville the other day, and they were telling me the nurses who work in ER, on any given day, they can have 7 admitted patients sitting in an ER, taking up beds that are normally used for people who truly need to come to ER. So I can only see that backing up more and more and more. If we keep making the cuts we're making and diverting people away from systems that work. And anytime you take us away from the bedside, that's direct patient care. And every RN you cut from a system is 1,950 hours a year of nursing direct patient care. So, and the more RNs you have, the better care you have. And every time, the stats are there that every time you add to an RN's patient load, morbidity and mortality goes up. Yeah. And that's patient outcomes deteriorate. There's more mistakes, there's more, the outcomes are not as good, and that's proved by stats.
So how are nurses feeling about all of that?
They're feeling very downhearted, overwhelmed, and they're already working as hard and as fast as they can. We have huge workload issues because the only people who are left in hospitals right now are truly ill. If you're well enough, you're out the door. You have your surgery, you're home. The only people we have in hospitals have comorbidities, they've got diabetes, they've got heart conditions, so they need to be in hospitals. And I do want to get them home fast, and I would like the home care system to have more money put into CCAC. But it was promised the last time and it never happened. When Harris did the big cuts in the 90s, all that money was supposed to go into home care. It never materialized. In fact, it cost the hospitals money to make these huge corporations that are still in existence. And they say they're now going to put more, I think it's 4% is going to home care. But they need to have the systems in place before they start shifting people. Because I deal with nurses every day who work in the community care access centres, and they're having to deny care to patients that Dr. Dworkin probably wants to get home from a hospital, and we can't get them home. You cannot send a 95-year-old man home to his wife who's 92 and needs services to keep him home if you're not putting the money in place. And they need money in place. It needs to be promised, it needs to be there, it needs to be functioning before they do the big move, which they never do.
Right. So from the perspective of nurses, you're just seeing cuts coming?
I see
as
huge
opposed
cuts
to
coming.
A reorganization, a rationalization, a reinvestment in other
That's
areas.
just another way of saying
efficiencies.
cuts. Because the baseline funding for hospitals, I think, was 1% as a minimum. And now they're going to a system called HBAM, which is how they allocate money for hospitals. And hospitals will sort of be competing with one another about how much money they get. So somebody does something better, or I can do that, the Queensway Carleton can do that better than the Ottawa Hospital, or vice versa. And they'll compete with each other, which I guess could be okay if they were all doing it to their best of their ability. But yeah, I don't like the competition part. I feel people, and the other thing is community. People have a different, they want to be treated where they live. And if I live in Cornwall, I don't necessarily want to come to the Ottawa Hospital for my treatment. And I see that happening as we regionalize everything.
Right.
And force bigger and bigger structures. Like we joke that we're all going to be part of the Ottawa Hospital one day. All the hospitals in Ottawa.
Right. So Barry, quick comment from you on those dynamics, on how everything in the system is interconnected. So something that changes in one place is going to impact on the other places.
It's the law of unintended consequences, right? It's as if you had this big spider web, or just web, and the patient's in the middle of this web being supported. Now everything holds that patient in place. And then you start snipping little parts of the web, and you can get away with snipping here and there a tiny bit, but eventually you cut and the whole structure collapses on itself. And that's essentially what will happen. And the point was very well made with regards to the nurses. I have a lot of nurses who are patients of mine, and sick leave, burnout, because they're completely overworked at the hospitals.
Right.
I mean, it's not a small problem. It's a big problem. They're physical injuries, emotionally traumatized just because they want to do their job and they're just overworked and they can't get things done. And that's what's directly responsible are the cutbacks that are occurring. So you're asking people to do more with less, and you can't. It's patient care. There's a standard that you have to maintain. So with regards to cuts in practice, we're seeing now, I am getting letters back from specialists now that the government has decided to cut the fees that the specialists can bill for tests that they do. So a good example, a real example, is a respirologist that I sent a patient to who has a lung condition that I want evaluated. And the respirologist sends me back a letter saying, because of the changes to the ministry's changes to our fees, where they can only bill 50% of what they normally would be able to for the fees, they want me to ask what tests to do. Because if I ask for it, they can get their full amount.
Right.
The problem is that a lot of the tests that they're asking about are tests I would never order because I'm not the specialist. It's a test that you do after you evaluate the patient. So you have a layer of bureaucracy that's now introduced, and in effect what will eventually happen is that the respirologist will see the patients, they'll send the patient back to you, they'll tell you, this is my evaluation, this is what needs to be done, please send that patient back to me, and the same tests are going to get done anyway. right? When you see a cardiologist, when you see a respirologist, they're going to order what they believe is necessary on the basis of their physical examination and your history to do the test. And that goes also to sort of being all in one area. When you have someone who's already there, who's already being assessed, and you can do the tests right away, and the investment has been made in the infrastructure, it's already there, and they have to cover the costs of running the machines and upgrading the machines all the time. It's easier for the patient to have everything done that way. But now it's hopscotch. Patient will see a cardiologist or a respirologist. That respirologist will send that patient to somebody else to get the test done, which will send back to the original respirologist, which then comes back to me, and the patient goes running around. That costs more money, more time. It's more fraught for errors because you have more interactions, becomes much more complex. And it's when you have people making decisions and making cuts that do not understand how that web actually works. And that web is complicated. It's not linear. There's multiple interactions everywhere. So you can't assume that if I cut here, it's just going to be a very straightforward result down the line.
Right.
It goes all over the place. And that's the issue. And that's what the problem is.
All right, we have to take a quick break, but when we come back, we'll talk more about the future of healthcare in our community and the impact of some of the changes that are coming, and also how doctors are trying to stop those changes from taking place. We'll be right back on Talk Ottawa. Want to stay up to date with the show or submit a question for an upcoming guest? Then follow us on Twitter @TalkOttawa and tweet your thoughts or questions. We want to hear from you.
To be on the District Health Council.
Right.
And it's an unpaid position, right? You're just on the council. And I would
Welcome back to Talk Ottawa. We're talking about the debate in Ontario over doctors' fees as the province tries to cut costs in healthcare spending. And the Ontario Medical Association has been pushing back, and we'll get an update on some of the discussions that have taken place and how doctors are responding to the health minister's proposed changes in just a few minutes. But let's talk a little more about how your practice works and some of the comments that have been raised in public by the health minister, Deb Matthews. For example, that family doctors are well paid, and on average, I think the number she threw out was the average family doctor makes something like $330,000, $340,000 a year. What's your response to that?
Well, my first response is I don't think you'd find any family physician complaining about what they're earning. But what they will object to is the amount that she's saying. For example, in our practice, it varies between $150 to $250. And again, that has to do with the number of patients that you're seeing and the type of practice that you want to run. It also you have to account for if a physician is working in a rural area where they're the only physician there and they're looking after 5,000 people. Yes, if they're in a rostered system, they're going to make that much, but they're looking after 5,000 people. So the ratio per patient still remains the same. The amount has to do with how many patients you're seeing. And the government encouraged us to take on more patients. In fact, in the last election, I think you'll agree, they said 2.1 million more people had family doctors. Well, if you have 2.1 million more people out of a total population of 12 million that have more family doctors, that's 15% more people that have family doctors in the province. That costs money to do. You have to cover the costs for that, and all the infrastructure and all the ancillary services. So when you make a blanket statement and you state it as gross income, right?
Right.
It's not representative truly of what is going on, because the physician is, by contract and also by their pledge to take care of patients, provide the environment within which you can provide the best care to your patient. And so that's where that 40% taken right off the top. So someone that's making $250 now, it's $100,000 that goes directly into the practice every year. Someone's making $150, it's $60,000 that goes in. So it's not a matter of the total, it's a matter of what value people are getting when they come to the practice. And to state a salary as if it means that you're not working for it, and without giving context for it, is not appropriate. It's the number, you're looking after patients. The more people you are providing care for, the more you will make. But that's as in any endeavor. The harder you work, the more you will.
Sure.
But you are getting value for money for each of those patients in terms of their health care.
And I think one of the other points that you've raised is that people have to look at it in the context of what it's costing the system for the different things that they're accessing through a family practice. So if you were to say to a patient, look, if you're going to go and see your physician, here's how much it would cost, here's how much it's costing the system. You're paying it not out of your own pocket, but you're paying it indirectly. Do you see the value in that? And
that's correct.
And when you mention the fees, it doesn't sound like it's a lot of money.
No, for example, the one of the major contentions, and again, it can get pretty boring to talk about the different fees and such, but to give an example, every month a physician is remunerated an average of $2.50 per patient in their roster per month to look after all the extras that have nothing to do with the patient visit. Right. So the prescription renewals, all the consults that come in every day, the telephone calls, making sure the charts are kept up to date, making sure all the lab results are acted upon, interacting with the specialist and calling up the specialist to deal with patient issues, clarifying things, faxing stuff, instructing the nurses on how to follow up with certain patients after leaving messages. All that infrastructure all that work is remunerated at $2.50 per patient. It's not a lot of money when you think about it, but if you have 1,600 patients, that's almost $4,000 a month. So so what they want to do is they want to remove that. They're saying, oh, it's a small amount, it's $2.50. Well, yes, if you present it to the public that way, it doesn't sound like a lot. But when you look at the overall effect of having 12,000 patients in our practice, and you remove that is, and as I mentioned earlier, the actual costs of running the practice, that now really puts us in the red. And it makes it very difficult to provide those services. And that means patients will either have to come in now to talk about things as opposed to dealing with it remotely, because we don't have the staff, because it'll mean staff cuts. We don't have the staff to support us to be able to communicate with the patients all the things that they're more than capable of doing, and easing the burden so that we can see patients coming in.
So if these changes are implemented, are you saying you're going to have to cut staff from your family practice?
There's no other choice. We're already dealing with a razor-thin margin. We are providing very efficient care, and it's a well-oiled machine. But as I said, you have to have the people available to help and support those services. And by having ancillary care, by having extra people helping out, it means I can see the more severe patients, the ones that have more chronic illness.
So how many doctors and other employees do you have working in the
We have
practice?
10 physicians. We have 4 nurses. We have a mental health nurse. We have 1 registered nurse and 2 RPNs. We have 10 support staff. There's also in our practice, we have an athletic therapist, chiropractor, and a massage therapist. And so it provides, we have and it's a large space, it's about 6,000 square feet of space. And the plan was to get 2 more physicians and with the income from those physicians, hire a nurse practitioner, hire a physician assistant to do even more of that ancillary care. Because when you do that, you get an exponential result, because now you have people that are able to, you're essentially getting people to do a lot of the plan that has already been set in place for your patients. And now, instead of them coming in to see you and taking up those appointment times for which more complex patients can be seen, you have the ability to provide at the same instant. Instead of being able to provide care for one patient, you're now providing care for 4 patients at the same time.
Right. So are you not going to execute that plan if these fee changes come into place?
The problem is that the government has capped what it's paying physicians. That is, it's saying there's a total amount for all the physicians in the province.
Right.
And there's 700 new physicians coming on. Now, granted, there's going to be some retirements from year to year, but 700 new physicians every year for the next 4 years. That's 2,800 more physicians amongst a pool of 25,000 physicians. Not all of them are family doctors, about 10,000 are family doctors. But the problem is say billings, and each of these physicians is going to see patients. It's not a matter of paying them for nothing. They're going to see patients. They get paid for seeing patients. So you then say, okay, so at the end of the year, the government adds up how much it pays all those physicians, and they go, oh, look, we're $1 billion over because utilization, more patients we're seeing, so we're going to take $1 billion back, claw it back, which is exactly what they did in the 90s.
That's what they're going to do then.
They will they're going to cap it. So they're saying the physicians are responsible for covering any extra costs for the new physicians that come in. But what that means, and people say, well, yeah, you guys can afford it. That's not, the point is that it's going to be at least 10% clawed back. That 10% clawed back is 10% less to the practice, because for the following year, they're going to take that away from you, on top of all the other cuts.
But will you then have to cut jobs from
You have to cut jobs. There's no other, and there comes a point where you cut and that spider web just collapses right down and you have nothing. So you can't cut to the point of nothing. You can only cut a certain amount, at which point, as you aptly said, is that the system breaks down. It breaks down way before you make all the major cuts. It breaks down even after 2 or 3 people are gone, because who's going to make the appointments? Who's going to call the patients? Who's going to deal with the nursing issues? Who's going to deal with the prescription renewals? Who's going to deal with managing the test results? I mean, it goes on and on and on. Aside from all the other stuff our nurses do, we've trained nurses. We pay for their education. So there's a CME fund that the physicians have set up for our nurses, so they can go train for extra diabetes care, spirometry, being able to use the spirometers, getting expertise in areas that they're interested in. And if you lose those people, you lose that expertise, and you can't, there's only so many hours in a day that you can provide that care.
Go ahead and jump in here, Ann.
Well, the same thing is actually going to happen to nurses who graduate from universities. Now a baccalaureate is entered to practice, so they've just spent 4 years getting a nursing degree. And we found they were all leaving and going to the States, especially University of Windsor. Like, their whole class just moved to the States. So the government came, yes, and that was happening for years, because they were guaranteed full-time jobs. Because there's a student debt, they want a full-time job. They want to do what they want to be a nurse, they want to work and take care of the community. So the government came out with the New Grad Guarantee, which in itself is a great program, because it takes a new grad in Ontario and guarantees them 6 months of full-time work in a hospital, nursing home, or wherever. There's a portal that they go into, and then after that they will then post into a job wherever they have got the position. Well, if we start having cuts and layoffs, that's definitely going to be affected, because you can't be laying off senior nurses and new grads who haven't even got, haven't got a job at that facility yet, so they'll be the first to go out the door. So on the one hand, they're spending money on a program, and on the other hand, they're cutting it. Like, they need to decide what they're doing.
So it's not just family practices, but it's also clinics that provide services. You gave me an example of one clinic, for example, that is going to see its fees cut and has just invested in a whole bunch of equipment. So it's going to take longer to get a return on that equipment.
That's it. We have radiology services where you have independent facilities that have paid for their own equipment. There's one center in Ottawa. They see, for example, 15 people at a time to do ultrasounds, which means you have an ultrasound machine in each of the rooms. Those machines are a fortune, hundreds of thousands of dollars each for those machines, and they upgrade them every few years because the technology changes, it gets better, and as you said, you want to practice with the best equipment because you want to provide better diagnosis, better care. And so, you're spending literally tens of millions of dollars in this facility that you've made these investments with the knowledge that there was a certain fee structure. And now they're saying we're going to pay you half. Or you have a situation where, in this case, a radiologist may see a particular result and they go, well, now we have to go forward and it could be a cancer, it could be a breast cancer, and you want to do an extra test, or you want to do, it's going to get to the point where you can't do that because they're only being paid half for self-referrals, half for doing these things. So the onus will be then to send the patient back to the family doctor to say, this is what we found, this is what we think needs to be done, could you please order these tests? They have to recoup the money that they've spent on these machines, or they have to get rid of them. So it's not a matter of, oh, well, we want to make more money for ourselves. They have a business that they're running. They're providing an excellent service. Let me tell you, the turnaround time is very quick. You have someone you suspect has a breast cancer or has abdominal pain, and you want to get an ultrasound done quickly or a mammogram done quickly. It's done within 24 hours or even the same day. And that's because you have these facilities that are offering that kind of service. But if you curtail or reduce their ability to cover the costs, each of those ultrasound machines has a technician. Each of the radiology machines, the X-ray machines, has a technician.
Right.
There's electronic infrastructure. There's electronic records. It's a big place. And so when you cut things all of a sudden, how are you supposed to maintain your services? Now, when somebody just turns around without warning and says, bang, you're cut in half.
All right, we have to take a break, but when we come back, we'll get an update on how doctors are responding to the proposed changes, and we'll talk more about the impact on local health care. We'll be right back on Talk Ottawa. Do you have a comment about the show? Then go to rogerstv.com, follow show listings to Talk Ottawa, and send us a message with your thoughts or ideas. We want to hear from you. Welcome back to Talk Ottawa. We're talking about the future of healthcare in our area, especially at a time when the province is looking at cutting costs and reducing fees for doctors. And maybe you can give us an update, Barry, on how this discussion is going, because there was a discussion, then the province said we're just going to impose a solution, and now it seems like there's a discussion again.
Right. The question becomes, can you trust a group that has already regulated or legislated you before you even had a chance to negotiate? Because once you do that, there's no more trust. It's bad faith bargaining. Right. And so you still have to get back to the negotiating table. You still have to talk to people. The government has to understand how practices work. They have to understand how fee structures work. When the physicians presented their initial offer, it was a freeze. There was no increases in fees, and the effort to find cuts in $250 million worth in cuts. That was the initial offer. Now, usually from that point, you can go on and say, okay, can you make it up to 300 or 350? But by speaking to the physicians to do that, we know how the fee structure works, and you could probably find, and likely find, areas where you cut some of those fees without imposing the unintended consequences that we talked about.
Right.
And so right
So
now...
you're feeling like the negotiation is a case of saying, well, we'll negotiate with you,
but if it doesn't
go well, we've already got a plan for how we're going to do
exactly,
this.
and they've already said what their plan is.
Yeah.
So we've asked for a conciliator to be part of it, and they've refused. Not an arbitrator. An arbitrator would decide on things. A conciliator is just to try and make it easier for people to talk to each other, and they've refused to do that. So it's very frustrating, and frankly, we are fearful of what is going to happen, because they can essentially, there's no control. They essentially can impose what they want, and that's not good for any workforce. When you're not listened to, when you are denigrated in the media and being held as the whipping person, I would say, for the problems of the healthcare system, it does not bode well, because it's hard to step back from that rhetoric once you've uttered it.
And give us an update on the dialogue between nurses in the province and what's happening there.
It's not just the hospital sector that's affected. We're also seeing there's going to be freezes in long-term care. They have collected all the stats for their funding, and we've been told they're getting a minimum increase. I think it's 1 or 2%, and yet they have the stats that prove, our members have collected it for them, that they actually need a much higher increase in order to maintain the level of care that they give to residents today. And also, one of the other areas that we're really concerned about is public health, is having to ration what programs they fund within their funding envelope. And one of the ones that concern us the most is the Healthy Baby, Healthy Children's program. And that's the Healthy Baby, Healthy Children's program. It guarantees that a new mother will get a phone call and a visit as a follow-up to being in hospital. And a lot of public health units in the province are cutting that universality and only focusing on high risk. And that's not, we feel that that's a perfect opportunity to start a mother and baby off on the right road and prevent problems down the road, which will then become a societal problem that could be corrected, and that's a false economy. But public health units are making decisions based on their funding, and that's one of the programs they're cutting.
So let me ask you both, in the time that we have left, what's the alternative? Because I guess some people, either in government or defending the government, would say, well, look, the government's got no choice. The costs are getting out of control. There's nothing they can do. They're going to have to cut. So what are some of the alternatives?
They have costs that they control. The local health integrated network is a huge cost to this province. It's a layer of bureaucracy that was added that costs millions and millions of dollars a year. And all it does is put a buffer between the local community and the minister. And they're responsible to nobody but the minister. There's no public input. All the appointments were done by the government, so there's no dialogue, and they make the decisions that affect the healthcare locally. That needs to be looked at. Now, I know Tim Hudak was going to abolish them. I'm not saying abolish them, but how they are run, what they do with the money, because the money comes from the ministry to the LHIN, and then it's distributed. That needs to be looked at, because the layer of bureaucracy is huge. Also, we're all public servants in a way when we work in the healthcare system.
Sure.
And there's a layer of high bureaucracy who are a huge cost to the healthcare system, especially in hospitals, because they're very well compensated. When CEOs are making $750,000 a year, and that's rather high for a publicly funded system. I think that needs to be looked at. There are ways to save money, and they need to have a dialogue with the stakeholders, and that's something they really have never done.
So Barry, what's your advice to the government on how money can be saved, how costs can be kept under control without doing what they're proposing to do?
Well, I think you have a government that is fixated on a specific ideology, not willing to make changes to other areas of expenditures that they're wed to. So that's one of the areas where there's billions of dollars that have been either wasted or spent that may not have necessarily been the wisest decision. But I think the biggest issue is We have, when you look at StatsCan and the amount that is being spent on healthcare every year, it's a linear increase of about 7% a year. So, and that's not going to change. That's going to continue to go up. You have older population, more chronic disease. And so as a result of that, you have to ask, what have other places in the world done to try and deal with this issue? Right? Not reinvent the wheel, not enforce hardship. Look at other universal systems and see which works well. And there are many that work well and have better outcomes than we do and function at less cost. Good example is our Ministry of Health has 10 times as many administrators as all of Germany to run their healthcare program. Right? And Germany has 80 million people. We have 12 million people. So there are a lot of aspects to how healthcare is managed and how it is funded that certainly can be picked up and learned from in other jurisdictions, because the rest of the world does things very differently. And compare apples to apples, a universal system to another universal system. Take what works best in that system and incorporate it. Try and find ways that look at ways that they have saved money and made things more efficient for patient care. And right now that's not what they're doing. They're sticking to one way of doing things, which is rationing care, because they have one model and they want that model to continue to fit despite the evidence that it is unsustainable the way it is set up right now.
So cutting the bureaucracy, if you compare Germany to Canada, that's one area obviously where big savings could be achieved.
And others are, again, look at what other countries do. They have some countries have mandatory insurance that everybody has to have. People that fall below a certain income line have that covered. Others have to get that insurance to cover the extra costs of the service. So for example, in family practice, it amounts to about $5 a month per person in order to maintain that service. That's some of the systems to look at.
All right. Thank you both for being part of the discussion.
Thank you very much.
Very interesting. And thank you for watching. We'll see you again next time on Talk Ottawa. Good night.